This week on the Backtable Podcast.
In terms of, must-have equipment, I think adult diapers are very helpful.
Welcome, everyone. This is Michael Barraza welcoming you to the Backtable Podcast. Backtable is your source for everything IR, from devices to tips and techniques and challenges. Today, we're going to be doing a podcast on IVC filter retrieval, and I'd like to welcome our two guests. We've got Rob Ryu from Denver, and we've got AJ Gunn from Birmingham. I'd like to let you guys just tell us a little bit about yourselves, tell us where you are and how you got there.
Yeah, so my name is AJ Gunn. I'm an interventional radiologist and assistant professor at University of Alabama at Birmingham. I did medical school in South Dakota, where I'm from, and then residency at the Mass General Hospital in Boston, followed by a fellowship in IR at Johns Hopkins, and then I was working at Washington University in St. Louis before I came here in 2016.
I'm Bob Ryu. I'm the Director of Interventional Radiology at the University of Colorado, where I've been since 2014. Prior to that, I was on faculty at Northwestern University for what seems like many, many years before I came to Colorado. And it's a pleasure to be here today. Thanks for inviting me.
Yeah, we're really excited to have both of you on here. You guys are both very well known in our community. Myself, I'm about 2 months out of fellowship at the University of Pennsylvania. I'm working in Nashville, Tennessee. So what I'd like to do is have you both just tell us about when and why filter retrieval became an important element of your practice, and tell us about your filter retrieval service in its current state and how it's evolved. Maybe go ahead and start with you, Bob.
Oh, sure. Gosh, my interest in IVC filters goes back probably to when you guys were in high school. I'm sorry to say. I guess I got more interested in filters probably in the mid-late 2000s. About the last 10 years really is when things got very interesting. And that was kind of matched up to the advent of retrievable filters. And, you have to remember back in the day, again, when I was trained, there was basically, one filter and it was permanent. Fine, you could have a Venatech, or you could have a Greenfield, you could have a Bird's Nest. That was kind of, or Simon-Nightingale. And when retrievable filters came onto the market, that sort of changed everything. We went through this whole iteration of tethered filters, which we're kind of coming back to now with the Angel catheter. I guess we can talk about that a little bit later. But, there's been this really interesting evolution of the devices. And as it became clear, in the late 2000s, that there are a ton of retrievable filters that are being put into people and never being retrieved. That's kind of when we started to realize there was a little bit of a, bitter harvest that we as interventional radiologists were going to have to come to terms with. And that was all those people who had these filters in, and they were having problems with it. Not to mention, kind of what we knew in terms of their ongoing risk of occlusion and DVT and post-phlebitic syndrome, and you name it, all the device-related complications, but also the devices themselves causing problems. So that's really kind of when it got more interesting, in the last 10 years or so, and we really started to focus on retrievals, both how to get better at making sure we follow patients, trying to prospectively identify the patients who really need a retrievable filter, and then getting really good at taking them out technically.
And I come in, really on the back end of this. And, for me, it was, joining a new practice out in St. Louis, and there was like 14 practitioners. And, as a new IR, a lot of it was trying to find, where do I fit in? Because there's plenty of people who want to do interventional oncology, and there's plenty of people who wanted to do PAD and DVT lysis and dialysis work and all these other things that were going on. And so you kind of have to sit back and say, okay, well, where am I going to fit in? How can I help this practice? And how can I help us develop our practice even further? And so it wasn't like I came out of fellowship with this passion for retrieving filters, but when I looked at our practice at Washington University and thought, here's something I can do. Here's something that we aren't really doing. And also for me, it was like a nexus of, as Bob mentioned, following our patients. And that's something that has also come along in the last, 5 or 10 years in interventional radiology is clinic and following patients and establishing ourselves as a clinical specialty. And so that was also something that I was interested in and passionate about. And so, setting up a filter retrieval program, finding a way that we can, change our notes, change our templates, see our patients back in clinic, that was something, that fit as far as the clinical aspects of IR, and also something that I could contribute to the practice. And so that's really where it just kind of started for me in, finding my place and where I could fit into my new practice.
Absolutely. So how did you start that when you wanted to help build what was there at UAB? What did you do to start increasing the volume? Yeah.
So, and I'd be interested to hear Bob's thoughts about this as well, because I really kind of saw it as, first, I needed to convince my partners, right? And then I need to convince referring physicians, and then you kind of like look out to direct to patients and those kinds of things. And so the first thing I really did is the same thing. When I got to UAB, I sat and I said, okay, like, what are we doing now? Which was not a lot. And I said, okay, sat down with the group and said, here's something I'm really interested in. We're trying to build a new interventional radiology clinic here at UAB. And I think this is one way we can start to, get patients to come into clinic, because we can, set them up for follow-up in 2 to 3 months after we place their filters. And whether or not we take the filter out, we've at least put our nickel down and said, sure, this filter needs to stay in or this filter needs to come out. And so, first, I'm not saying my partners weren't skeptical. They were all for it, but, there needs to be data there. There needs to be showing them, hey, listen, here's the complications of filters. And it's really changing people's mindsets, because the first thing you hear is, well, why do they need a second procedure? And I'm sitting here saying, really we need to change the mindset from why do they need a second procedure to why they need to keep that filter in. And once you start to change your mindset to give me a reason that filter needs to stay in, you'll find that a lot more of the filters will come out.
Yeah, that's fascinating. It's also a challenge. That's something I think we all run into is, educating our referring providers about when these filters need to be placed and when they need to be removed. So just out of curiosity for both of you, roughly what percentage of the filters that you're removing were placed by your department?
What percentage of filters we were taking out? Well, certainly early on, it was, virtually 100%, that it was very kind of insular. But, we weren't making a conscious effort to chase these patients down. And that's really, that was kind of the first step of developing the practice. It was kind of becoming accountable for the filters that we were implanting. And that was sort of the seed of the concept of what we were trying to do. I give a ton of credit to Bob Lewandowski and Kush Desai, my two ex-partners at Northwestern, who were just as instrumental, if not more so, in trying to drive what we were trying to do. And it started with that. The other question you asked with regard to, how we built the service up, it started with being accountable and starting a clinic, which I think was helpful, but we realized that, the whole clinic thing didn't have to happen. It frankly was inefficient. And what it became was more of a virtual clinic. In other words, just making sure that we were reaching out to patients, reaching out to referring physicians, and being accountable and really making a conscious effort. That's how it starts.
And I think, I would add on to that. I mean, I think referring, for a long time, interventional radiologists have deferred that decision about whether the filter should stay in or stay out to the referring doctor. And that's great in some instances, but in a lot of instances, these can be nurse practitioners out in the community, physician assistants, primary care doctors who are worrying about other things. They're not worrying about necessarily their patient's IVC filter. And we found that when we've seen patients in clinic, just sending an email to the referring doctor saying, hey, we're going to take out the filter because of X, Y, and Z, they're happy with that. And they're really pleased that someone, like Bob is saying, is taking responsibility for that, because it's not in their wheelhouse, and it's not in their area of expertise, and it is in our area of expertise. And so it's a way we can provide an extra level of care for our patients and being responsible to that. And, you mentioned physician education. I've just had so many experiences in the last, few months where, referring physicians they just don't really understand how filters come out and those other kinds of things. And so just sitting down and saying, I had one referring physician say, well, their DVT was in their right lower extremity. Don't you have to go through their groin to take the filter out? And you just realize people really don't know what we do. And when you sit down and explain to them how we do it and what the data is behind it, I think they get more on board that way.
Yeah, I mean, it seems for me like a lot of people are still expecting these to be for prophylactic use. And so, I run into a lot of discussions where people are like, well, had a filter before. I mean, it's had a clot before, what's going to keep this clot from coming back again? And it's like, it's not the filter. So, as you started to take accountability of these filters, how did you ultimately reach the point where you were getting referrals to remove more of these that you hadn't placed yourself? Was that word of mouth, or was that something that came from direct contact with these other doctors?
We are probably let Bob speak to that a little bit more, since his practice is a little bit more developed than we are down here at UAB. I mean, we're still at the point, to your previous question, where most of our filters we're taking out our filters. I can think of 5 or 6 patients in the last 12 months that have come from outside. That's usually been I can think of 3 situations, really. It's come down to, one has been there's a referring doctor, somewhere in the region that tried to take the filter out and said, hey, why don't you just go to UAB and see if they can get the filter out? Number 2, patients get online and start to search because they've had doctors in their hometown or wherever they're getting their care that says this filter can't come out. That's really been the second. And then the third has been, other physicians here at UAB who have heard that we're starting to take more filters out that say, hey, I've got this patient's had this filter in for, 4 or 5 years, and would you consider taking them out? That's kind of really where the ones, even though it's a small number, that's kind of in the 3 groups of patients that we've seen.
Okay. What about you, Bob?
Yeah, it's interesting. How did that happen? In Chicago, I think part of it had to do with the fact that we started taking out some filters that, probably were beyond what people had originally been taking out, like what was possible. And we were writing about it. We were trying to be pretty rigorous with regard to publishing some of our approaches to this. We were on the internet. And, it just seemed kind of like word of mouth got around a lot. Obviously Chicago's a pretty big referral area. And so, cases came in from around the city. Next thing you know, they were coming from Indiana and surrounding states around there. And it got kind of a regional thing. Now you'd have to talk to Cush, who's just, he's just knocking out of the park there. You'd be shocked at the cases that he not just takes on, but he actually successfully completes. They're pretty amazing. I mean, I could show you my phone of the stuff that he texts me on a daily basis that are pretty hair-raising cases.
Yeah, I'm actually not surprised, especially after that recent paper he put out, which is incredible.
Yeah, it's pretty impressive. He's doing good work. Anyway, I think a lot of it has to do with just kind of being in the community. I think social media is helpful as well, being on the internet and, talking to your physicians. Again, it's amazing how you get one patient from one doctor and sort of like what AJ's saying, you take a few minutes and you teach them what you know about IVC filters and your approach to it. And how this matters. And the next thing you know, they've got friends and, their partners, and that's how it starts.
So are you approaching both the doctors and the patients on, a doctor by doctor basis, or, are you going out there and doing any dedicated education of these doctors, lunches, conferences, things like that?
Ours has been, we're starting to dip our toes a little bit. UAB's been great about providing us a lot of resources as far as marketing and public relations, and they actually do some CME podcasts and things like that. So, we're starting to dip our toes in those waters of kind of, marketing out to groups and marketing out to physician groups. But a lot of it has been, a little of this slow go of, one neurosurgeon here, one vascular surgeon there, one primary care doctor here. But I agree with Bob. I think, when someone sees that you're responsible and that you care and that you're knowledgeable and that you're not, trying to be a cowboy, right? That you're trying to do what's right for their patient and you're being responsible in following these things up, there is word of mouth, especially in these really integrated hospital systems. And I don't think that, I think once you start to do those kinds of things, that it almost spreads. I don't want to use the word like wildfire, but it spreads around pretty quick that, Dr. So-and-so is taking out filters and is taking out, is doing these advanced techniques. And pretty soon you're going to start seeing these patients, show up but it takes being responsible and being accountable to patients and to referring doctors for sure.
Okay. Now, are your groups, the interventional radiology department, are you guys the only groups that are taking out the filters in your hospital system, or, cardiology and vascular surgery trying to take some out as well?
We have both kinds of partners, and all three of us provide that service. I think the more technically challenging cases end up with us.
Yeah, I know our vascular surgeons definitely place filters. I'm imagining the straightforward retrievals that I honestly haven't ever seen them do a retrieval, but I imagine that they would feel comfortable doing it. But complex retrievals, I don't think that they've attempted yet.
It's been quite a surprise to me coming from an institution where IR dominated the filter landscape. I was naively surprised to find where I am now that cardiology and vascular surgery were kind of running the show regarding even the more complex retrievals. So that's something I've had to kind of work through on my own. But I think at this point, if it's okay with you guys, I'd like to go ahead and switch gears a little bit and talk about how you manage your individual patients, starting with clinic. Which patients are you seeing in clinic beforehand? Is it every patient, or even the ones that had a filter you placed a few weeks prior?
For us, our protocol is what we do is anytime a filter gets placed, one of our physician assistants places. We can create patient lists inside of our electronic medical record, which has been nice. And so all of our physician assistants and myself have access to this patient list. And so anytime a filter gets placed, they go onto our patient list, and then an email goes out from our physician assistant to our nurse practitioner, our nurse coordinator in our clinic, who schedules that patient for an appointment in usually 2 to 3 months from the time that we place the filter. Okay. And so at current, we are seeing all of our retrievals in clinic beforehand. I don't have many. I can't think of many that are 2 to 3 weeks out. That we play. I suppose if the patient was still in the hospital and was post-operative, and they said take the filter out, I don't think I would need to see them in clinic. But for the most part, even the prophylactic ones, that go in, patient gets discharged, we see them in a couple months, and we talk about whether or not it needs to come out. And I don't know. For me, I feel like it's a good thing. I think it establishes our clinical precedence, for one. And two, it just avoids any, you guys know how interventional radiology department runs. Sometimes people show up and, there's missing information or those different kinds of things. And so this really avoids that for our filter patients. They get down, they've got a half hour, 45-minute consult with one of our physicians. And that's where the anticoagulation gets sorted out. That's whether, all of these other issues kind of get sorted out. And I think it's been really good for our practice to see them all in clinic.
Right. What about you, Bob?
No, we don't routinely see the filters that we place, standard case. They're coming back in 2 to 3 months. Unless there's a question or there's something unusual about it, we'll just go ahead and schedule them. All of our patients are followed through a separate database that's maintained on a shared server, and we all have access to it. We have a terrific group of mid-levels who manage our database and kind of keep track of people, and they sort out 99.9% of the issues before the patient ever gets back to the hospital. So when they come in, usually it's, they've already talked to them, they figured it out. We've been in touch with their referring physician, et cetera. Right. So it's smooth. The only people we really see in clinic are somebody coming from outside. We don't know what kind of filter they have, or we know maybe it's been in for 10, 20 years or whatever. Something of an unusual case, somebody who's had an attempt elsewhere. Those folks will always see them before we try and take it out.
Now, will you get imaging beforehand?
If needed, unless they've got, recent imaging elsewhere, or, somebody tried to take it out last week and bent the hook and they sent a picture of the bent hook. Usually that's about all I need to see. Unless, again, there's some issue of the patient's demonstrating, some evidence of venous obstruction, in which case we'll at least get ultrasound, if not CTV.
Okay.
To lay things out.
Now, you bring up the patients who have had filters in place for 10 to 20 years. Do you have any hesitancy to remove longstanding filters in asymptomatic patients, or really any filters fair game for the most part?
Yeah, I think that's a great question, and is kind of like all of medicine, it's a patient-specific decision. A fairly common scenario is somebody comes in who's had a filter in for 10 years and they've been on anticoagulation. And the only reason they're on anticoagulation is because they have a filter in place. And, given the low risk of the retrieval procedure itself and the hopeful outcome that they'll no longer require anticoagulation therapy and its attendant risks, I don't think that's a real hard case to make in terms of at least making an attempt to retrieve the filter. We've all gotten pretty good at it. The technology's improved. We've gotten, we're getting a lot more practice with getting these really difficult, old, sort of crumbling filters out. So the risk is low and the potential upside is high. So I have very little hesitancy in offering those people the opportunity to get off their anticoagulation. The other scenario is somebody comes in with an asymptomatic fractured filter, and they're not on anticoagulation. What is your responsibility to that patient in the setting of a filter that is already fracturing? And if it should fracture in the wrong place, they're looking at a metallic cardiac embolus. Again, you could make the argument, well, the patient's asymptomatic, and, both these scenarios, by the way, I'll say, assuming these patients do not require mechanical prophylaxis. In other words, they don't need the filter anymore. Again, in both those scenarios, I think it's pretty easy, at least for me, to have a very upfront discussion with the patient about the upsides and downsides of what we're trying to do, and why we're doing it, and explain very clearly, here, we could just leave this alone. We don't know what'll happen, but maybe this, maybe not this, who knows? You got to decide for yourself.
I'm with you. AJ, how do you feel about this?
No, I mean, I would agree with everything that Bob said, but also I think you have to realize that there's a lot of people, I would say a lot of interventional radiologists who, feel less comfortable and may kind of say, hey, well, listen, if it's not causing you any problems, let's leave it, because there are, maybe some risks associated with filter retrieval. And I don't know that that's the wrong decision. Obviously, that's not something that neither Bob or myself would probably agree with, but I definitely think that, sitting down with the patient and explaining what the thought process is, and then kind of say, here's the risks, here's the benefits, and we can go from there, I think is very important.
Now let's switch gears again and start talking about the technical side of these. So hypothetically, if you were starting a filter retrieval from scratch at a new hospital, what's your must-have equipment before you start scheduling patients? Starting with you, AJ?
Well, it's kind of interesting. So we obviously, for us, I always just start with the snare device. I mean, you have to have one of those, obviously. And after that, I'll go to usually a reverse curve catheter and a glide wire, and creating a glide wire loop snare, either that or forceps if it's a tip embedded. So to me, if you're going to do like filter retrievals, I mean, at the bare minimum, you've got to have a loop. You've got to have a loop snare. You got to have the glide wire, and probably forceps if you're going to do anything complex. We share a space here at UAB with our EP folks, and so we actually had a laser. I don't know. I mean, I don't know if like a laser is an absolute requirement. I don't think so. I mean, they're expensive. And when we started here, I was not credentialed to start using the laser, and that's something that that we've had to work on to get credentialed to use the laser here at the hospital. But there's definitely one that I failed getting out. It was a Gunther tulip that was 11 or 12 or 13 years old. Had it hooked and ready to go, and had I had that laser ready, I would have been able to get it out for sure. I was not able to oversheath it, and so I think having the tools ready up front is really advantageous, especially if you're going to get aggressive and start taking out older and or permanent filters.
Okay. Yeah. Penn, interestingly, we had the laser and didn't use it. Scott Chertola carries 100% success rate with the forceps alone. And so that was going to be one of my questions was whether or not you've had instances where you wouldn't have been able to get the filter out without a laser.
Well, yeah, that was the first one, and it's just I usually kind of tell everybody is like, if you pull hard enough, you'll get it. And I had it with forceps, I had it with a glide wire loop snare, I had it with a regular snare, and I had it hooked and had it oversheathed about 80%, and I just could not get that last little bit, to go over the sheath. And maybe he lifts more weights than I do or eats more meat than I do, but I just I pulled as hard as I was comfortable pulling at the time.
Bob, what about you?
In terms of, must-have equipment, I think adult diapers are very helpful. I think
I was going to let me talk over you just for 1 second. Big sheets. That was the other thing I had to have was big sheets that we didn't have when I first got here.
I was hoping you were going to say diapers.
French. Yeah, no question. It's nobody ever says, "Gosh, I wish I had used a smaller sheath on this case."
Yeah. Yep.
And so when in doubt, if you're even thinking you need a bigger sheath, you need the bigger sheath.
Okay.
And 16 is a good go-to sheath. 18 if you're feeling it. And certainly, there are occasions when you go bigger, and you can use a dry seal or whatever, one of the Gore products. For me, I think the biggest, the quantum shift, technically was definitely the forceps. Loop snare is great. Again, the bigger sheath certainly makes things a lot easier, but now, it takes about somewhere between 1 and 2 minutes of fluoro time to know whether or not you're going to get a filter just using a snare. Mm-hmm. And if I'm not getting the proper tactile feedback, I just go straight to forceps and take the filter out.
Okay.
That takes care of 90%.
I'm sorry, go ahead.
And then we use the laser overall in about 10% of cases.
Okay. Do you always start out with the smaller sheath and go with the loop snare or the retrieval kit, or do you occasionally start out with the 16 French or larger sheath?
The only time I'll start with a 16 is if I know I'm in for a dog fight, like, an Opties,
sure,
Opties, or, something bad. But standard, patients coming back 3 months after we put the filter in, no, I'll just use a standard, 10 French, depending on what device, you're coming out with.
Yeah, I mean, I think, if someone's come to you for the outside, I mean, I can think of one that was an Optease that was failed outside retrieval, and, we got IJ and femoral access and kind of went through and through and did some stuff with some larger sheaths. But, we had another patient kind of self-refer. She had I think a tulip or a select, I can't remember, for, 7 years. And, we went in and had the laser ready. I had everything ready, right? There was a lot of hubbubaloo around this case just because I was like, okay, I want everything ready just in case. But, just to decrease the anxiety in the room from the techs and nurses, like, we're just going to do what we normally do, right? So my fellow goes in, he grabs it, and we oversheath it in less than 5 minutes, right? And we're just done. So I think that there's a lot of, value in sometimes just starting with what you normally do, unless, someone's already tried that on the outside or you have imaging to show that it's going to be a very difficult retrieval.
Okay. Just kind of a controversial topic. Are any of you using femoral bailout technique? I think it's at Sinai where they go in. It's the filter aversion technique.
Oh gosh. Have you done those, Bob?
Not on purpose.
I haven't. They don't make UAB. I haven't found adult diapers large enough yet to accommodate that. There's one where there was a guy who, I thought about it, but we did some other things that got the filter out, but have not attempted one myself yet.
Okay. Just some more questions about the technical side. Do you guys do a rotational cavogram or just like a traditional AP cavogram before removing these?
Yeah, we do a venogram, not with cone beam CT or anything like that, but yeah, just a traditional cavogram just to make sure that there's no clot in the filter or anything like that.
Oh yeah, absolutely. I always start with a cavogram. We don't routinely use DynaCT unless there's a reason that you need to see the 3D reconstruction. I think an interesting topic was actually from your old program at Penn. They did a very nice study a few years ago looking at post-retrieval cavogram, right, which, I don't routinely do and haven't for many years, assuming the filter comes out easily. But I always do it whenever, as soon as you cross over into the adjunctive techniques world, then I automatically do one just because, I was a little bit more paranoid about those cases in terms of caval integrity. And in fact, it was nice to see their write-up, large series that basically said exactly that you really don't need to do a cavogram after routine retrievals and that you probably should after adjunctive cases. Nice paper.
Yeah. So you brought up another important point is clot in the cava. How do you manage that? And how do you approach it when you see clot either within or below the filter?
Assuming that, speaking of that Penn paper, I changed my practice after reading that paper. I always used to do a cavogram post, and I read that paper, and I was like, what am I doing? This is not even worth it anymore. I don't know where I heard this or read this, but, I just kind of use 25% of the filter. If it's less than 25% full of clot, I'll still pull it out if it's all full of clot. And if it's all full of clot, then it just really depends if it's symptomatic or not, right? If there's caval thrombosis and the patient's symptomatic, then obviously you're going to start to do, catheter-directed thrombolysis and thrombectomy, and the filter's going to come out and those other kinds of things. So, but unexpected, I just can't remember that many cases where there's been unexpected, asymptomatic, significant amounts of clots in the IVC or within the filter itself.
Yeah, I routinely, we use a similar number, 25-30% of clot volume, to determine whether or not you can take it out. That's probably conservative, to be honest with you, but it's a number that's published and the number that we stick with. And if we see it, we keep patients on anticoagulation. We have them come back 6 weeks and we do it again.
Okay.
Can certainly do a CTV and save the patient, potentially having another cavogram. But, usually when they come back at 6 weeks, I can only remember one patient who hadn't cleared at 6 weeks and actually needed a third procedure in order to get their filter out. I think the most important thing is that, you don't give up. And that's sort of the thing that you see happen, and people sort of attribute that to, well, we're going to call it permanent now because there's clot in it. I think that's a mistake, and I think that patients really should be brought back for another attempt.
So I thought maybe we'd just spend a brief amount of time talking about the filters you place. I don't know if you guys are like me. I think we're all using the Optis as our go-to filter, right?
Yeah,
100%.
Definitely.
So Scott Chertola called the Optis the thalidomide of filters. I was hoping you guys could both share what you guys are routinely using, both in terms of retrievable or temporary versus or when you're placing them permanent filters.
So we've been mostly using the Bard Denali filter. In fellowship, that's all we placed. Whether or not the filter was going to be permanent retrieval, we were just placing Denalis for everybody. And I think at UAB, that's typically been a lot of the practice is that everybody's getting a Denali filter. I've been trying to work with the residents and the fellows just to kind of, think about it a little bit more. And if you really want someone to have a permanent filter, you think it's going to be in there, then let's do a permanent filter. And the one that I've, just been most comfortable with is that Venatech LP if we're going to use a permanent filter.
Yes, I'm a big proponent, actually, of permanent filter use in the right patients. And we've written a little bit about that in terms of trying to determine, how patients are best served by that. Aaron Eichler, who's now a fellow at Northwestern, several years ago, helped write an algorithm for developing a calculator to develop likelihood of retrieval. And this is, based on some prospective data we collected. So I'm a big believer that there's still a role for permanent filters. And I think that with the problems that we see with retrieval filters, it's pretty easy to make that case, again, to optimize the utilization of these devices. In terms of retrieval filters, I'm kind of an agnostic. I don't have a particular brand. We try to use all of them. We're at a training center too. And so the more types of filters that our trainees get an opportunity to deploy, the better, I think. Sure. But that said, there are a couple of manufacturers that we do tend to avoid that we actually don't stock.
Okay.
And I'll leave it at that.
We had just started using we were using the Venatech Convertible at Penn when I was there. And, we'd use the Venatech LP, which I really liked. Have any of you ever actually converted one of these Venatech Convertible filters? I have not.
I haven't either, actually. We were one of the sites, both in St. Louis here and Birmingham for the Century trial, but for the Century filter, but I have not converted one of the Venatech's convertible ones.
Yeah, I have, but it's been a while. It's funny. It's such an interesting product.
Right.
It's an interesting device. It's, but it's sort of looking for a home and trying to figure out where does it fit into the paradigm of device choice. And, I'm pretty convinced it's out there. It's just, we can't even come to any sort of agreement right now, not just within the IR community, but extend this into all of our clinical colleagues as to whether there's really a difference between permanent and retrievable filters, let alone, we're going to throw another one in there called Convertible, which is kind of a hybrid device. So, it's an interesting device. I think it's pretty slick. It's just a matter of trying to figure out where it fits in.
Yeah, it's really interesting. I mean, it's similar to a retrievable filter, and that for most of these, if you're going to convert it, you're bringing them back and converting it. Was it pretty challenging to do, or is it pretty straightforward?
No, I think it's very straightforward. The only thing I'll tell you is that, so I use N snare, like that's kind of my go-to snare for retrievals. Do not use N snare for the convertible filter. Use the regular loops.
The Amplatz gooseneck?
Yeah, gooseneck. Sorry. Thank you.
You're welcome.
Now. But that is what you need to convert. Do not even try to use anything else. Chaos will ensue. And don't say I didn't warn you. But it's easy to do. It really is. You just have to, read the little device thing, watch the video. It's very simple.
I just have, I always just have a little bit of a concern, like when you're leaving something behind, either with the Sentry filter or with this convertible filter, you pull the top off, but it still leaves the barbs or the tines behind. And just knowing that anything inside the veins could eventually cause this to thrombose or, the inflammation that it causes, I just don't know what that looks like, going forward.
Yeah, well, I think everybody shares that concern. I think that it's, what I think most people draw somewhat of a correlate to is the Gianturco stent and how those stents, in terms of patency, it's simply not an issue. They're so big. And the thing about it is that I don't know if you've held a convertible in your hand, but they're much less robust in terms of the size of the metal. These struts are more delicate, but we also know that, it seems that those devices are pretty robust. If, they're comparable to a Venatech LP, you don't really see Venatech LPs, or at least I haven't, where they're fracturing and migrating, that kind of thing. And that again, there's a similarity to that design in that it's stable. So while it does raise those issues, I agree with you 100%. It does alleviate other issues that I think, again, it's a hybrid device. It's not the cure-all, but it definitely, I think, can serve a role for, the selected patients. The question is, who are those patients who are best served having that device?
Absolutely. So if it's okay with you guys, unless there's anything else you think we should cover, I thought I'd wrap up by covering a few questions that came up on Twitter. There were several from Sabine Don, one of which asked, when do you decide to stop a difficult filter retrieval, and how much is it okay to leave behind, if anything?
I think, I guess I have a ready answer for this because I already shared that a little bit. I stopped a difficult filter retrieval when I was pulling and the patient was uncomfortable, and I just didn't know how much more torque I wanted to put on the patient, and so we stopped. As far as I wouldn't love leaving anything behind if I thought it was intravascular, and that's why I think maybe cone beam CT sometimes is helpful because the struts, they perforate, they're outside, and so if you pull the filter out and the struts in the retroperitoneum, like that doesn't bother me, right? I do a cone beam CT and that's the strut that's out in the retroperitoneum. I'm not worried about that. But if it's something that's intravascular that I'm worried is going to go, just like what Bob was saying, you don't want to have, an intracardiac, metallic foreign body. There's just bad outcomes for patients with those things.
Okay.
So I'm not sure how much comfortable I would feel leaving something behind if it was intravascular. Now, that being said, we were writing something up and I was looking at the MOD database about some migrated filters, and there's plenty of patients in the MOD database who had intracardiac migrated filters, and they were just treated with anticoagulation and just left alone. And I don't know what the outcomes of those patients were, but clearly, it's a decision people are making at times.
Yeah, so I'm trying to picture what that conversation's like.
Yeah, I know, right?
Hey, I've got some good news and some bad news for you. The good news is we took your filter out. The bad news is you got a piece of metal in your heart, and you're just going to have to live with it. Yeah, that's pretty awful. Yeah. So when do you stop? It's a great question. So I used to do all these with conscious sedation, and now I've gone to doing a lot of the complex ones, certainly the Cordis products. I'll do those with general anesthesia.
Interesting.
Yeah. Do you do that? Do you do them under GA, the complex ones?
No, I switched to, I was, so I went to the SIR session this year with, Cush and, Lewandowski and Brian Hawley from Hopkins, and Bob Lewandowski mentioned that complex ones he does with Mac, and so and that's what I noticed, in my own practice. Like anytime I opened up those forceps, the patients felt it. Every time he opened up, they're like, and so I have switched over to using Mac when I think it's going to be a complex retrieval for sure.
Yeah, I've totally gone that direction. I mean, I think it's just easier to work. And I used to be very much a believer that if patients started to get symptomatic when you were pulling on their filter, that it was a warning sign you're about to do something awful.
Yeah.
And I've kind of gotten away from that a little bit. I was a very, very firm believer. I was pretty dogmatic with the fellows about, when a patient starts to yelp a little bit, you better be paying very close attention to what's going on and how hard you're pulling. But now with these complex ones, we're so much more aggressive. And I think we're all developing a little bit more of a comfort level with what the IVC can take. And quite frankly, how forgiving it is as a vascular structure. We're all kind of recalibrating, I think, at least a little bit with what you can get away with in terms of taking these things out. As a personal policy, I never leave stuff behind. If I can get it, I'm going to get it. It really has to be embedded for me to give up. And I'll spend a lot of time trying to take out these little fragments piece by piece. And that's the other bit of advice I'd give people is, you've got to be patient with these things. They take a long time. And, that's another good reason to use your anesthesia colleagues to help you because, you can be in there for 3-4 hours, taking these things out and picking away at the broken struts and, chasing them down in various parts of the vascular anatomy. It's no fun.
Well, gentlemen, in order to keep you two from being with us for 3 to 4 hours, I think I'll go ahead and take this opportunity to close today's episode, unless you have anything else you'd like to add or to bring up.
Yeah, 2 things. One, I want to shamelessly plug the active meeting, October 5th to 7th in Phoenix. SIR sponsoring Active, which is a meeting devoted to filters, actually, filter retrieval, as well as PERT, acute and chronic DVT. I think the faculty's great, and Kush and Bob have done a great job of putting that meeting together. I'm really looking forward to the hands-on workshop for filter retrieval. We've got all these models that Mike Itagaki put together for us. So it should be a lot of fun and some good cases, things like that.
What kind of hands-on models will you have?
Oh, you name it. From stuff that, things that we've talked about, obviously, all the standard techniques, forceps, lasers, loop snares, et cetera. There are a couple of device companies actually are coming that have devices that are about to hit the market. The Captus device is going to be there. There's another one. I'm not sure they have approval yet, but we're hoping they'll be there. So there should be some pretty cool stuff.
Yeah, that sounds awesome. AJ, are you going?
I'm not going. But now I feel super sad that I'm not. I know. No, I was just going to say one thing. I mean, to the younger IRs that are out there, I think sometimes when you read the papers that are coming out from, Northwestern and Colorado and Stanford, you think, they're doing all these crazy things. And I think it can be a little intimidating when you're very first starting your practice. But I don't think that anyone would expect you to take out these extremely complex filters on your first try. But there's plenty of support out there, either through meeting people at meetings or reaching out through social media or reaching out through the SIR directory. There's plenty of people out there that have done this for a long time that are willing to, lend you their expertise and their knowledge and to support you as you, go about trying to pick up more techniques to take out these filters for your patients. So it's out there if you look for it.
Yeah. I'll echo that, AJ. I think that's really, really important. It was very tricky getting the laser up and running when we started that in Chicago way back when. I think Will was the only person who was using it at that time. And, there's some subtleties to using it, not to mention sort of the infrastructure issues that come with it. And so, I've been lucky enough to get to work with some people around the country to get them up and running. And I'm always happy to help folks. And there are things that I can help sort of streamline for those of you who are interested in learning laser and kind of figuring out how it works and all that stuff, I'm always happy to talk. I'm sure AJ, you are too. But it doesn't have to be a meeting. It can be totally informal. It can be an email, and we go from there with a conversation. And the more of us who are doing this, the better it's going to be. There are a ton of filters out there that need to come out, and we are way behind the curve. Somebody tweeted that. Was that from Sinai? I think yesterday, referring to an article, I think in Journal of American College of Cardiology. I can't remember. I should look on my phone, but they're commenting on how filter out and filter in is totally balanced, right? There are way more filters going in than filters coming out. And the more of us who get involved in this, the better it will be for patient care.
Yep.
Well, I think I will take you both up on your offer for advice at some point in the near future. But again, I just wanted to thank you both for coming and joining us on this podcast. This has been fantastic.
This was great. Thanks for having me.
Yeah, this was really good. And, we are hopeful that ultimately Backtable can be another one of those resources where you can learn from your colleagues and get advice on how to manage things like this. Thank you guys both. For our listeners out there, look for us at Twitter, on Twitter at @_Backtable. Let us know what you want to hear and how we can help. Thanks, everyone.
All right. Thank you.
Thanks, Michael.